Well, good morning, everyone. Thanks for coming out on this very hot June morning and being here so early in the morning in typical summertime. These events in the summer sometimes are a little bit difficult to get folks to attend, but as you'll be able to see or you've seen from our agenda, it's really some really pertinent information, timely information for folks, and we appreciate you being here. My name is Paul Klain. I am the president chapter of HIMSS Heart of America here in Kansas City, and again, thank you for coming today. We have a special treat for you. We have an agenda full of industry and subject matter experts who give freely of their time to be with us today. Before we get started, I would like to thank a few key people and organizations who without their contributions, these events would not take place. First and foremost, what a great venue here with Johnson County Community College. HIMSS Heart of America and the partnership that we have with Johnson County Community College and their Health IT Workforce Development Program has been very, very beneficial, both to Johnson County Community College and to our HIMSS organization. And over here in the dark suit with purple, that's Deb Elder. She's on our board. Please thank her for arranging in our event venue today. Thank you, Deb. Secondly, we have some sponsors who are helping to fund this event that we have here today. Three of our sponsors, our premier sponsor, Certified Data Systems and American Consultants and Net Standards are here. They have booths that are set up next door, and please take some time during our breaks and during the lunch break to visit with them and to learn about their services. Again, without their support, these events would not be possible. And last but certainly not least, our board programming chair, Linda Gerber. Linda, please stand up. Who with her leadership and guidance with the programming committee really brought together some great speakers. Thank you, Linda. Every event that we do seems to be getting better and better because of her guidance and the programming committee and the venues that we have here as well. So thank you, Linda, for everything that you've done, and I'm sure today's event will shine prominently upon your expertise. Thank you. HIMSS Heart of America is a healthcare IT professional association of volunteers in the health IT community. So not only do we have a few individuals on our board and some of these partnerships that we have with vendors here, but we rely on our members to put these events together. And your membership and participation in programming committees, attending events, the national event that's usually in February or March, those kinds of things. It's all about you, the members of the health IT community out here. So I'm putting in my little plug here for this is our last event for this fiscal year. Our fiscal year ends in June. We recently changed our board terms to being 2-year terms, so we're in midterm right now. We won't have an election this year, but we do have a few board positions that we would like to fill through appointments. So we have a members at large position and opportunities on the programming committee. If anyone would like to become more involved in your local chapter, please see me during the breaks or afterwards. Also visit our website at www.hoahimss.org, and that's probably how you learned about this event. We could certainly use more volunteers to help us put these programs on. So again, thank you for coming here today. I think you're going to enjoy the presenters that we have, and I'm going to turn over to our Master's Ceremony today, Linda Gerber.
Thank you, Paul. Well, welcome, and thank you for coming at 8 o'clock in the morning to be here for this. Like Paul already kind of covered all the bases, so I don't think there's a whole lot for me to do except for just second the part that if anybody wants to get involved with HIMSS and the programming committee, it's a great experience. You meet a lot of people, and you really learn a whole lot of new information, and it's a good experience. It opens you up a lot to what's going on in the community. With no further ado, I'm going to introduce Martie Ross, our first speaker, and thank you for being here so bright and early. She just got in from New York last night. Martie is with PYA. It's Pershing Young and Associates. They are specialists in the healthcare field. Following a successful 2-decade career as a healthcare transactional and regulatory attorney, Martie Ross now serves as a trusted advisor to providers navigating the ever-expanding maze of healthcare regulations. Her deep and wide understanding of new payment and delivery systems and public payer initiatives is an invaluable resource for providers seeking to strategically position their organization for the future. Martie can identify opportunities and develop realistic plans of action where others can only see obstacles. Martie has an uncanny ability to synthesize complex regulatory schemes and explain in straightforward and practical terms their impact on providers. She has made hundreds of presentations to professional and community organizations on a broad range of industry topics. Martie provides dynamic, customized educational planning sessions for directors, executive managers, as well as employee compliance training program. Welcome, Martie. Thank you.
So really, in short, I'm a recovering attorney. I want you all to pull out a piece of paper and draw a grid like this, okay? I'm going to give you insights into the Chief Executive Officer's brain early in the morning, okay? In one corner, I want you to write necessary evil. And then below that, I want you to write unnecessary evil. And then across from necessary evil, I want you to write necessary good, and below that, unnecessary good. This is how CEOs manage, is figuring out what goes in what box and concentrating on those items that live in necessary good. Necessary good are mission-critical activities that generate revenue. They're necessary in the sense that they are mission critical, and they are good because they make money. Unnecessary evil, are those things you have to do because someone tells you have to do it, so that makes them mission critical, but they cost money. So they're not generating any revenue, they're instead on the expense side of the ledger. So think of regulatory compliance activities, lawyers, and would we put ourselves as health information technology professionals in this category? And I think for years and years we have found ourselves there. Then below we have unnecessary evil. The CEO's main purpose in life is to eliminate unnecessary evil from the organization. Things that are just a pain and they're not essential and you don't have to do them and you don't make any money off of them. So we get rid of those. And then on the other side, final quadrant, we had the unnecessary good. These are things that generate revenue, not necessarily mission critical. And so in lean times, they find themselves under attack. Now, over the years, these quadrants stay the same, but where various programs live in those quadrants varies continually. And last week, I had the opportunity to speak with the Kansas Foundation for Medical Care's Quality Forum. So imagine a room like this full of quality assurance officers and risk managers and the like. And the story we told was, you have always lived in necessary evil. But in a new world order, with changes in the manner in which payers are reimbursing providers for healthcare services, you are going to find yourself quickly moving from necessary evil to necessary good. Because the activities in which you engage on a daily basis and how you lift up the organization are going to become essential to the organization's financial success. And you now, for probably the first time ever, find yourself in league with your colleagues in quality and risk management, because as health information technology professionals, you are going to go from that world of necessary evil, that we have to maintain medical records because they tell us we have to maintain medical records, transitioning probably over to with the beginning of meaningful use and the generation of dollars for meaningful use. You find your way now on that traverse over to necessary good. But what I want to talk about today is how you're going to firmly entrench yourself in that quadrant. That as we enter the world of value-based purchasing, The data generated through our health information technology systems are going to become the currency of healthcare. And those organizations that capture their data and are able to use their data effectively and efficiently are those that are truly going to experience economic success in this new payment regime, which we are now entering a decade of change to reach. So it's going to be a long haul. That's the first thing I want you to appreciate, is that you're not going to go in tomorrow and demand a raise claiming that you are now firmly entrenched in necessary good. Instead, this is going to be a 10-year process where you really have to be leading the charge as we reinvent a system from a fee-for-service reimbursement to a value-based reimbursement. And that value component to an organization is going to be driven by its data and its professionals that are able to use, collect, and deploy that data efficiently. Now, luckily, I have the easiest assignment today. I'm just going to tell you about value-based purchasing. I don't have to tell you how to use your data, which is great because I have no idea. Luckily, I brought Brian Worley with me, one of my colleagues at PYA, who will talk to you about big data and how to utilize it. So I am not in charge of that piece of the equation. But for you to appreciate where the world is going, I want to spend some time talking about the evolution to value-based purchasing and what pressures the industry is feeling today with respect to those new payment models. And right now I'm going to figure out how to use them. There we go. So let's start at the beginning, because if you talk about health care reform, people immediately jump to the Affordable Care Act. And so I'm going to give you a little bit of a primer in what's really in the Affordable Care Act. It's a giant piece of legislation, 1,000 pages, but there's a hard divide at about page 201. The first 200 pages are this first goal of the Affordable Care Act, which is providing access to care to a broader number of individuals. So that is government as regulator. That's government coming in and establishing rules on how the private insurance market is going to act. And our goal with that part of the legislation is to make adequate health insurance more available and more affordable, or the 3 A's of access: adequacy, availability, and affordability. And if you listen to media reports, this is 95% of what you hear with regard to health care reform. So I'm not going to talk about that at all today, except very briefly. The other half of the ACA, or actually the other 80% of the text of the statute, concerns the triple aim, which is how can we reform payment and delivery systems to provide better quality care in a more efficient manner to improve overall health outcomes. And that is where the genesis of value-based purchasing finds itself, in the provisions of the Affordable Care Act that address the triple aim. Now, on the first half of the equation, on the insurance coverage, on the availability, adequacy, and affordability, it's a very complex approach. What Congress identified, what we refer to as the 7-part solution, which involves insurance regulations, the creation of the health insurance exchanges we're hearing about so much today, the individual mandate, which was all we talked about last summer in anticipation of the Supreme Court decision, the employer penalties, which are now obsessive for many employers, figuring out, do we provide coverage? What kind of coverage do we provide? Are we better off to let them go to the exchanges? All of that chatter. And then finally, tucked into this was the issue of Medicaid expansion. And each state now having the decision to make whether they will expand the Medicaid program and accept the additional federal dollars, or whether they'll maintain the current program they have. And so it's obviously a complex regulatory scheme in which the community has to exist, but certainly it's not front and center. Because our question is, access to what? If you're going to improve access to care, what exactly are you improving access to? Is it high quality care? Is it care that's improving the overall patient health outcomes? Is it care that we can actually afford? And in fact, it's all about money. What we have to do on the back half of the ACA, and what we're committed to do as health information technology professionals, is figuring out how to deliver care more efficiently, because we cannot afford the system we have today. Simple as that. If you compare these numbers over a 10-year span from 2010 to 2020, it's faster than a rocket ship, the way these dollars are increasing, that we are going to wake up in 2020 and spending nearly 20% of our gross domestic product on health care. Every dollar you have in your pocket, you're spending 20 cents of that on health care. That's where we're headed if we're unable to bend the cost curve. That we will have every person in the United States with a price tag of nearly $14,000 on their head just to provide health care services for them. If we cannot control this, we cannot right up our economy. This is the challenge we have to address, bar no other. Certainly there are other components of the economy that require attention, but until you address healthcare costs, until we bring our costs in line with other industrialized countries who are spending half and less than these amounts and receiving better results for the dollars they spend, we are putting at risk our economic competitiveness in the world. And briefly, last week, the New York Times ran a fabulous expose, front-page story, on just the difference in healthcare costs between the United States and other industrialized countries. And as you can see, very common procedures, straight down the line, very commonly prescribed drugs, what the United States consumer is being charged for those products and those services far outstrip what other countries are charging. So considering the money equation on all this, I want you to keep in mind what we refer to as the first law of improvement. Every system is perfectly designed to achieve the result it achieves. What we have today, our system, is volume-based reimbursement. You provide a service, you get paid for it. There's no question with regard to whether it's a quality service, the manner in which it was performed. You just provide the service within regulatory constraints, and you're going to get paid for it. And really, the only effort we make to control those costs are regulatory definitions of medical necessity, when the payer will pay for a certain service, and then the fraud and abuse laws, which attempt to regulate relationships between providers to control referrals. That's really all we do in the sense of trying to control costs in a volume-based world. So if you apply the first law of improvement, our system is perfectly created to provide as much health care as possible. So you can generate, if you are a healthcare provider, every incentive is pushing you towards see as many patients as possible, order as many tests as possible, admit as many people as possible to the hospital, perform as many procedures as you can. As long as you can stay within the regulatory constraints, that is the economic incentive we have created. So it is no surprise whatsoever that healthcare costs are growing at such an exponential rate because we've set up a system to achieve that. So if you want to change the system, if you want to start saving costs, you have to start buying something different. You have to tell the system, I'm done buying volume. I want to purchase value. I want to reward you, provider, for providing better quality care, achieving better outcomes, and doing it in an efficient manner. So I have to rethink my system completely and identify rewards for those providers who can achieve the triple aim. And that's why if you're a CEO right now, you're having a hard time figuring out what lies in what quadrant. Because your quadrant was created based on a volume-based reimbursement world. And when you change to say, now I'm going to be paid for value, everything on the quadrants moves around. And so we are in an incredible period of discomfort in the healthcare system as we now are just starting to appreciate what change lies ahead. I mean, certainly these wheels were put in motion long before the Affordable Care Act was signed in March of 2010. Providers and payers had long realized that the volume-based system was not long for this world because we couldn't afford it. But as public perception was so centered around healthcare reform and the insurance component of healthcare reform, providers had some ability to bury their head in the sand and ignore this change coming. And I'll tell you, having worked now in this space for a number of years, you can truly see the attitude shifts, particularly since last summer, even more so since the election in November. as folks have come to accept the Affordable Care Act as the law of the land, they are now beginning to appreciate the need to start realigning the providers along a value-based system. So there's just been incredible change and appreciation in attitudes over the last 6 to 8 months. I think that's going to accelerate even more as more and more of these reforms come online and have broader impact. Particularly for the patient. From the patient's perspective, the system needs to change. Because we are really, as I say, naked on the table when it comes to the healthcare world. Because we are viewed in isolation, that each provider who provides services to us is not coordinating with other providers, that we have a siloed system, and so we are treated as silos. These are my allergies, this is my bad heart, these are my bad knees, and no one's really looking at me as a patient. And so a critical element of the transition to value-based reimbursement is being able to see the patient holistically and sharing data around the patient. And so for health information technology, it's not only a factor of tracking the quality of services performed and using those measures, but also providing an infrastructure so that the patient can be the center of care. Absent health information technology, it is impossible to patient-center care. It will always remain provider-centric. That health information technology becomes that thread by which we can weave together a system that centers around the patient and treats them holistically. And so with appropriate care management and with appropriate communication between providers, you start delivering higher quality care, far more efficient, significantly less costly to the system. And so if you're going to change the reimbursement system, what are you going to see change in response in healthcare? I put the dollars first. I say if you change the dollars, if you say provider community, to receive payment you have to do X, you're going to get a lot better result than saying provider community, we want you to do this, 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 and this, with no dollar reward at the back end. I mean, why do you think when you leave the hospital you don't receive follow-up calls saying, did you get your meds? Are you taking your meds? Are you seeing any unusual symptoms? You just want to talk through anything. Why does that not happen today? Because no one pays for it. And until someone starts paying for that or rewarding that activity, it's not going to happen. And so the reforms we're seeing are reforms to the payment system because that will drive changes to the delivery system. You've got to pay for what you want. And so as we move from a fee-for-service world and we go through shared savings, through bundled payments, to partial capitation, to the holy grail of global payments, if we are ever able to achieve that, you're going to see the system move from one that's reactive to one that's focused on particular conditions and addressing those conditions holistically, to one that is truly attempting to predict what's happening with this patient so that we can achieve the best health outcomes as a general population, but also being able to control costs because you never get patients to crisis when you manage the population health measure. And I don't even have to, I can see what you're thinking right now is this is all our ability to manage data. This is our ability to know that population through the data available to us on that population and know what constitutes an effective intervention to address and correct and prevent particular medical conditions experienced by that population. That is what drives all of this, is that ability to use that information effectively to achieve true population health management. And so it is foundational change. Don't fool yourself. We are not playing around the edges anymore. And while some of the early on reforms you've seen, such as meaningful use, meaningful use was, we're going to give you dollars to change your health information technology system. What we're doing now is saying we're going to we're going to pay you only if you've achieved meaningful use. And so it becomes a condition of payment as opposed to a reward for doing something. That's where the system is realigning. So the days of I do X in terms of meaningful use, and I get paid for them, are short for this world, as you know. Those are soon going to become penalties and no longer bonuses, payments. And the system's doing the same. It is saying, we're not going to pay you to implement an EHR. We're going to create a reimbursement system that necessitates that you have an EHR. So figure out how to do it effectively, economy. Figure out how to do it, provider. And that's the very essence of a capitalistic system, is you create the incentive and let the players figure out how to best achieve that incentive. That's the foundational change we're now undertaking. And you're going to see changes from just providing more services and only having medical necessity as a regulator, and that not understanding our costs at all. Healthcare, and this has become exposed more and more with CMS now releasing cost data on inpatient and outpatient care. Healthcare has to be the only industry in the world where costs are a function of charges. That we figure out what the costs are after we've been paid for what we delivered. Makes no sense whatsoever. And so it now becomes a protocol-driven system, that we apply best evidence and utilize evidence-based protocols, that we rely on quality measures to tell us if a provider is doing well and adhering to the evidence-based protocols and the patient is experiencing the outcomes that are expected given available research. And that we learn to track costs, that we start creating efficiencies in the system so that we are actually able to determine what it costs to deliver health care and then be able to reduce those costs in an effective manner. Well, back to the ACA. I will now get down off my soapbox for a bit and actually start talking about the substance of what's in the Affordable Care Act and where it's driving not only the federal health care programs, which granted 65% of our healthcare economy are federal programs, state and federal programs, but also what is driving what's going on in the commercial market as well. Again, one of the few industries where government is actually the leader in innovation. What is achieved through the Medicare and Medicaid program, TRICARE, VA, the other federal programs, lead the commercial payers. The commercial payers have figured out they can sort of draft on the wind created by CMS and the other federal agencies in designing new healthcare payment and delivery systems. And that's certainly what they're doing with regard to value-based purchasing. But the two strategies I want to talk about in the ACA address payment based on quality performance, so pay for performance. And secondly, rewards for clinical integration. Where are we trying to teach providers to work together and incentivize them to accomplish that? So starting with that first strategy, which is payment based on quality, we're going to talk about 4 specific tactics in the Affordable Care Act. The readmission reduction program, hospital value-based purchasing, which there's 2 kinds, physician quality reporting, and physician value-based purchasing. And I would submit, and we'll talk about this, that number 4 is what's going to change the world. Because until you change physician behavior, we're just messing around. We're trying our best, but once you change the physician behavior, you've changed the system. So we'll warm up to number 4. Hospital readmission reduction program. So the New World Order started on October 1st of 2012. When CMS went live with the readmission penalty and value-based purchasing, or at least the first part of hospital value-based purchasing. The readmission penalty is based on a 3-year historical average of 30-day readmission for 3 conditions, AMI, heart failure, and pneumonia. And so CMS takes its data, identifies patients that were discharged based on these DRGs, and then looks to see if that patient was readmitted to another acute care facility within 30 days, regardless of the reason, regardless of the facility. And that calculated a readmission rate. And you achieved up to a 1% reduction in all of your DRG payments based on your readmission rate. So this is only a penalty. There's no reward in the sense that those that had low readmission rates received additional funding. Instead, this was just a reduction on those who have seen patients coming back in the door, either their door or someone else's door. Okay. Now we have the annual excitement over the publication of the proposed inpatient prospective payment rule, how CMS intends to change its policy with regard to payment for inpatient hospitalizations. That was published last month. And in that rule, they proposed to expand this list to include hip and knees as well as COPD. And so starting in 2015, or actually October 1st, 2014, CMS will recalculate that data with these now 5 conditions and determine the readmission penalty rate. The rate of the penalty also goes up over time. This year, we sort of warmed up at 1%, and we had 2,200 hospitals that experienced penalties of about $280 million. Not a lot of noise, we're just practicing. But next year, that goes up to 2%, and thereafter, it's 3%. And given how close margins are in hospitals today, a 3% penalty can be very challenging for a hospital organization. So readmissions become critical just on the bottom line finances. But also it's now becoming a game of perception in the community because these are transparent numbers. Anyone can log on to Hospital Compare and look at the readmission rate for the hospital where they're about to have a procedure performed. And it can become part of not only consumer selection, but private payer, because commercial payers are looking to these numbers as well. They're not calculating their own. They're not looking at their readmission rates. They're looking at the Medicare rates because that number's right there and readily available for them. And for no investment whatsoever, they then have a way to distinguish between the quality of different facilities in making narrow network determinations, making provider network determinations. The same is true with employers. One undeniable trend is employers are going to be more directly contracting with providers and eliminating the middleman of insurance to the extent they can. So starting wellness clinics or preferred networks, whatever it may be, employers certainly will look to this data in evaluating the hospitals with whom they wish to partner. Well, does this program work? I mean, $280 million is less than a drop in the bucket when you're dealing with healthcare costs, but it seems to be changing behaviors. It seems to be refocusing providers on the need to avoid readmissions and the costs associated with them. Last month, the Institute for Medicine released a report talking about Medicare readmissions, and historically, it has sat at 19%, unmovable 19% for over 5 years. But last year, in 2012, it reduced down to 18.4. Now, less than a 0.5% reduction, but that's 70,000 avoided admissions. And considering the average payment for Medicare on an inpatient admission, that generates significant savings, far beyond the $280 million that were saved because of the penalties to the payers, penalties to providers. This is actually affirmatively avoiding having to pay. Now, granted, there's a question, there's white noise over there regarding whether this is just a change in hospitals using observation status as opposed to inpatient admission. But certainly there is some change going on. And very focused interventions have truly proven to be effective. Minnesota's RARE campaign is reducing avoidable readmissions efficiently. RARE has been up and running now for about 5 years. They have broad participation statewide. They have achieved in a short period of time, 3 years, a 17% reduction in hospital readmissions. That is moving the needle significantly. And they've identified those interventions that work effectively. And as you see, all of these are a part of how that system has used their data, how they've identified those patients who are at risk of readmission and been able then to target interventions. And certainly when you read about RARE, they talk at length about the backbone of data analysis and how that's enabled any of these interventions to be effective. So rarereadmissions.com is the website. You can get more information about what they've done very successfully. So from readmissions to value-based purchasing. This has been a long roll forward, beginning in 2003 with the hospital reporting requirements, that hospitals were required to report on certain measures to avoid a cut in their payment updates. And 90% of hospitals have begun reporting data, and I'm sure some of you could share experiences, how enjoyable it is to collect that data and report it to CMS. But we built on that with ERA, with the HIT Act. We added to that the meaningful use incentive payments, and that included a significant commitment to improve quality reporting as part of the standards. And then with the Affordable Care Act, we've added 2 new pieces to the puzzle, the DRG modifier, as well as the hack and never event penalty. Now, beginning with the DRG modifier. And this is an adjustment to the manner in which hospitals get paid on a DRG. So we do a combination of quality measures and patient satisfaction reporting. Information that the hospitals have historically now been reporting for several years since the Medicare Modernization Act. And we calculate a performance score, and it's certain magic that CMS runs on their computers to tell hospitals you have a positive number or you have a negative number. If it's a positive number, we're going to multiply your usual DRG payment, and you're going to get more. If it's a negative number, we multiply your DRG payment, and even I, who is mathematically challenged, knows that that actually reduces the amount you receive in payment. The beauty of this for CMS is it's budget neutral. They simply withhold 2% from every hospital and then redistribute that 2% based on your value-based purchasing scores. And again, this went into effect. The first round of these value-based purchasing adjustments began on October 1st of last year. And though it starts now at a 1%, we will again increase that number moving forward. And so more and more as those scores on this whole broad range of measures in terms of clinical process of care, as well as patient satisfaction. Every year, CMS will adjust these. Yes, it's really small because there's a lot of data here, but every year these will be readjusted appropriately so CMS can incentivize where it wants to see the hospitals move, and hospitals can become sensitive to where they're performing on these different measures. The next piece of hospital-based purchasing, hospital value-based purchasing begins in 2015 with the greatly named hack never event penalty. I mean, whatever you do, you don't want to have a hack or a never event, right? Just sounds bad. Beginning in 2015, we're going to take all the PPS hospitals and we're going to score them in terms of their experience on hospital-acquired conditions and never events. Very common terms that we've been familiar with since the Institute of Medicine CHASM report, that there's certain things you should never acquire in a hospital in terms of infections and events that should never occur. You know, if you're going in to have your right leg, have surgery on your right leg, you don't want to come out with a bandage on your left leg, right? That's a never event. So we will take all the hospitals, score them on these measures. Those that are in the top quartile, so those that are experiencing the highest rate of hacks and never events, will see a 1% cut in their payments. Heck, I don't care about the 1%. I just don't want to end up on a list called, top quartile and hack and never event. Because talk about transparency, that's the first thing I'm going to look at if I'm going to go in to have a surgery or to be admitted to the hospital. I want to know what their hack or never event rate is. And if they're in the top quartile, that is not a hospital I want to deal with. Or I actually want to be the marketing director for the hospital across the street from the hospital with a high hack or never event rate, right? Because I want to be really sure that I advertise our impressive rates in those regards. The never events are those which most folks in healthcare are very familiar with these days, such as, volume of foreign object left in the body. That doesn't sound like a good thing. I would call that a never event in my book. But then the hospital-acquired conditions we're going to look at are central line, blood infection, and catheter-associated UTIs. So things that the quality folks have been working on for a long time, have been asking you for data on for a long time, now become critical because they're going to dictate what we're going to get paid. They're going to impact our GRG payments for Medicare, and you can expect Medicaid and the commercial insurers not to be far behind. Now, appreciate, again, remember your CEO who's trying to live in those 4 quadrants, that they're stuck in those quadrants. And that really we place folks in a rock and a hard spot because every incentive now moving forward is saying improve performance on these measures. But the old crusty, well-worn but well-entrenched volume-based world is saying, we're not really quite ready for that. And a study that came out in the Journal of the American Medical Association in April really hit this point home. it looked at hospitals and surgical complications. So hospitals that had higher rates of surgical complications, how do you compare their financial performance to those that had aggressively addressed surgical complications and had reduced them effectively? So they analyzed data from a single hospital system with 10 hospitals across the southern United States. And they figured out that those hospitals that had higher surgical complications had higher contributions to hospital margins. It pays to screw up your surgeries if you're a hospital. Now, granted, that's only true on the programs that pay well, Medicare and commercial insurance. And so if you're actually operating on a Medicaid patient or an uninsured patient, you want to be sure to provide them good quality care, because otherwise that will cost you. But can you imagine, how exactly do you manage to these pressures that exist today? And we refer to this as the Canoe Issue. If you're going down the road, you're going down the river and you've got one foot in this canoe and one foot in this canoe, at some point you've got to commit. But it's certainly not going to be a pretty ride for a while. And so appreciate the pressures this is placing on the system and the discombobulation we're all feeling as a result of these pressures. Let's flip over to the physician side of the house. What are the pressures on our physicians? There's been in place for a long time PQRI, which was the Physician Quality Reporting Initiative. It also dated back to the Medicare, the one that started the Hospital Compare. Medicare Modernization Act. There's so many. If you ever look at all the acronyms, it'll drive you crazy. I still say COBRA sometimes, so I'm supposed to say EMTALA. Starting back then, we started, instead of with hospitals faced a penalty if they didn't report their data. Physicians, by contrast, were eligible for a bonus if they would report in quality data. So they would just submit reports. We didn't look at the scores. We just wanted them to learn to report. And it had lackluster participation at best. But we are now in the transition period under PQRI, which has now been renamed PQRS. It is now a Physician Quality Reporting System. They're serious when they go from an initiative to a system, right? But under PQRS now, we are now facing penalties for physicians who are not reporting their quality measures. And this is the bellwether year in 2013. Because if you're not reporting in 2013, you are first foregoing a bonus of 0.5%. So every payment you receive from Medicare on your volume-based reimbursement, you're going to get 0.5% more. So if it paid $10, it's going to pay whatever 0.5% of $10 is in addition. See, not mathematically challenged. And so there's the incentive piece that you're losing if you're not reporting. But more importantly, if you don't report in 2013, starting in 2015, you're going to get cut 1.5%. And so it's a 2% wash for not reporting. And again, physicians on thin margins, that can make a significant difference in their overall income. And then starting next year, if we don't report next year, it's a 2% penalty, and that carries forward. And so this is one piece of the puzzle physicians are facing, and they're starting to figure out the need to do reporting, either through their claims, through registries, through group reporting options, all of which we have obviously a component of their ability to use an electronic health record. That ties to the meaningful use incentive payments. I think of any group I don't need to review these with, is that the reality of this is this stops being a bonus and starts being a penalty. And that transition is going to happen here in a very, very short period of time. So building on that basis of quality reporting, we now start looking at quality performance with the introduction of the physician value-based payment modifier. And this is the game changer, because this will bring physicians' attention to this subject. It is on a long, long glide path. It begins implementation in 2015, full implementation in 2017. So we're still 4 years out from physicians being paid by Medicare based on the quality of their services. Now, beginning in last year, in fact, here in Kansas, physicians received a physician feedback report. And that document was quality measures based exclusively on claims data. So this is Medicare's ability to go in and look at claims data and line that up to performance measures and give a physician a score. So it's transparent to the physician. They do nothing. They are passive. And claims-based quality measures certainly aren't the most reliable. They aren't particularly sensitive, but they're easy to gather the information. And that report the physician received gave him or her the scores on those measures as compared to peers. And then also had some very rudimentary attempts at efficiency measures. And again, scored the physician against his or her peers, same geographic area, same specialty. CMS is now in the process of refining that report and will begin producing that report on a broader scale this year. So more practices across a broader number of states are going to begin receiving the modified version of the physician feedback report. But what happens in 2015, at which point every physician should be receiving one of these reports? Physicians in larger group practices will be subject to the value-based modifier, and then in 2017 we bring all of their brethren in small practices along. So for hospitals that employ large physicians, they're going to be facing this in 3 years with the 2015 adjustments. And in fact, it's your performance today as a physician in 2013 that's going to impact your 2015 scores. So we're in the thick of this. They don't even have a clue. I mean, most physicians just sort of like white noise, and you talk to them about it, and they're like, really? But you can see the lights go on because they very quickly appreciate there's going to be a scorecard. I'm being compared to my peers. I'm back in medical school. I'm competing for an A because I know my grades impact my career opportunities. And they understand my scores on these value-based purchasing measures are going to impact my reimbursement. And the most incentive-sensitive people I have ever met in my life are physicians. That if you change the incentive at the end of the game, they will figure out how to get there. So once they begin to appreciate these scores dictate my payment, they're going to be very sensitive to them. Just in terms of pure mechanics, it's another budget-neutral program, always our favorites. So we put so much money at risk, and a physician, based on their quality indicators, based on, they will get either a positive number or a negative number, and you multiply that by their fee schedule adjustments. And it doesn't take much creativity to start appreciating the usage of that grade. That Medicare can score you, but commercial insurers can follow right behind. Malpractice insurers can use that number. Hiring decisions will be based on that. Narrow networks by commercial insurers based on that. And eventually, patients. Because this is, again, the heart of this is transparency. And while the report is confidential, the score and your modifier at the end of the day is going to be available. And so the sensitivity here is going to be significant. Well, now this is the last piece of the puzzle. I've been talking about a glide path to 2017 before all physicians are online, but as usual, things may accelerate. And what's going on in Congress right now, and a very interesting debate to follow, is centered around the SGR Fix. SGR, Sustainable Growth Rate, which is the magic formula Congress enacted about 15 years ago on how to maintain and control costs on the Medicare physician fee schedule. And so we reduce the amount of payment to physicians dependent upon the medical inflation rate and the difference between actual inflation and medical inflation. Very complicated formula. Don't want to bore you with it. Really don't understand it myself. But as you know, we've every year come up to a point of saying, well, the SGR tells us we need to cut physician payments by 5, 10, 15, last year 30%. And every year Congress says we can't let that happen. No kidding. And so we have to figure out a way to make up that gap. And so every year we end up with an SGR fix. And you know, in January of this year, as part of the grand budget scheme, we did the doc fix by taking the money from the hospitals primarily and plugging that in. Now, the original price tag for fixing the SGR, actually correcting the formula over a long term, had been set at about $250 billion by the Congressional Budget Office in November. But surprise, In February, they say, well, wait, we're going to readjust those numbers because we're seeing declining expenses in certain areas. And so actually, if you want to fix this formula, the budget impact of it's only $138 billion. Well, hey, that's peanuts, right? One can budget around $138 billion. And so the conversation both in the House and the Senate, both among the Republicans and the Democrats, is an SGR fix, which really, at its heart and soul, is a souped-up version of physician value-based purchasing, and an acceleration of that program and expansion of the impact of that program. Really, at the end of the day, the amount of dollars at risk on the value-based programs are not, devastatingly impactful. The idea here under these proposals is that it certainly would be a difference, that we would have measures that are developed by the professional societies, in conjunction with CMS for particular types of physicians, and the scores on those quality measures as well as efficiency measures are going to dictate a value-based modifier similar to what we're seeing. And so again, this is one of those reasons physicians are beginning to pay attention, because their professional societies are focused like a laser on this, because all the legislation involves the professional societies in the identification of the appropriate quality measures. And so it's beginning to trickle down through the press, through the professional societies, to the physicians. They're beginning to see the attention focused on this. Performance measures are certainly never pretty, and I think I alluded to previously that we rely heavily today on claims data for performance measures. There is a significant interest in enhancing and improving performance measures, and last week or the week before, the Commonwealth Fund published a report about achieving the potential of performance measures and targeted in on 7 particular areas where we really need to enhance our ability to judge the quality of health care. And the message of the report was, we have the data. It is, however, untamed. And until we start taming the data, and once we tame the data, we can really start evaluating provider performance. And one of their primary recommendations is that we really need to bring some logic to the system. That right now, you have different agencies that say this is a good measure or that's a good measure. We really need some standardization in the system, similar to the role that the Securities and Exchange Commission plays in standardizing financial reports so that you can truly compare the performance of this company versus that company. We need to bring that same sanity into healthcare measures. And so this report is getting an enormous amount of attention. It is certainly focusing in quality leaders on these need for measures and appreciating that they need to learn a way to walk down the hall and talk to their friends in health information technology and the ability to use data to match these measures up. So you're going to see this trend, I think, accelerate very soon. So that is enough on the first strategy. Remember, we were talking about the 2 strategies under the ACA for driving value-based reimbursement. That first strategy was paying for quality. The second strategy is incentivizing clinical integration. How do we get providers to start working together with patient-centered care? How do we start evolving relationships between providers? And the volume-based world has really driven a wedge between providers, particularly at the hospital and physician level, because we have placed hospitals in the positions of being the policemen for the physicians. If you've ever lived through the wonderful world of peer review process in a hospital, you know the tension and distrust that process builds between hospital administration and the physicians on the medical staff, and that they view each other as competitors. And if you certainly familiar with the movement of physician-owned hospitals, physician ancillary services trying to take a piece of the pie as the hospitals view things, physicians saying running it the right way is their defense. So they've been competitors. They've been at each other's throats in terms of being antagonistic, and the loser, of course, in that is the patient. So how do we start readjusting that relationship? How do we create incentives for folks to get along, or at least how do we remove the incentives that have turned them into competitors and built antagonistic relationships? And that really is, how do we build incentives for care coordination, provider collaboration? How do we reward that behavior so that physicians start adhering, defining and adhering to evidence-based standards of care? And those strategies are around the topic of clinical integration. And if you need a whole new buzzword, the one I hear more than any right now in the industry is clinically integrated networks. Is getting providers to work together on a common set of rules, and diverse providers, not just family practice physicians working together, but family practice specialists, subspecialists, hospitals, long-term care, the entire wraparound being part of a clinically integrated network. And that network really defines their standards of care and enforces them, and then centers around care coordination. In the Affordable Care Act, there are three tactics under this strategy, and certainly we'll see more develop. But briefly, let's talk about payment for care management, accountable care organizations, and bundled payments. Fee-for-service payment for care management is new. CMS only began paying for this year. It is a post-discharge transitional care payment. A physician can receive dollars for managing a patient for 30 days post-discharge from institutional care. CMS brought this online with great hopes, and it sort of fluttered because providers have had a lot of concern about how you actually deliver this service, and you can see this kinks in the system attempting to work themselves out. And we're hoping that this year CMS will go one step further and begin creating payment for long-term chronic care management. So a patient, for example, who has diabetes is managed by a physician to control that condition. They would receive payment beyond just the traditional payment for evaluation and management services. Second tactic, one you've probably heard about here or there, something called an ACO, Accountable Care Organizations. And really, to appreciate accountable care organizations and what we're going, you have to do a little bit of historical perspective. Now, of course, this had to be the day I forgot to wear my watch. So it's 9 o'clock. I've got 10 minutes to talk about this. Awesome. Okay, we're good, right? I have 10 minutes to talk about this, right? Okay, good. Elliot Fisher, fascinating gentleman. He's a physician who is the head, or was the head, he may actually be past chair now, of the Dartmouth Atlas, which is a program at Dartmouth College where they have for years analyzed CMS claims data. And what they really have tried to understand is, why does it cost $1,000 to treat the patient in this community and $3,000 to treat the exact same patient in a different community? Geographic variations in Medicare reimbursement. Why does that happen? And in 2006, Dr. Fisher appeared before MedPAC, and they discussed this issue, and he reported his findings. And he says, we have sliced and diced this every way we can. And what we have found, that the areas that have higher rates of spending have a greater supply of health care services available. More physicians, more MRIs, more inpatient beds, you name it. Very supply-sensitive services, where there's more opportunities for providers to refer to those services. That generates a higher bill at the end of the day. There's just more services available, so we feel compelled to use them. Interestingly, however, those high-cost regions are also, almost without exception, the regions with the lowest scores on quality indicators. So he takes all that hospital compare data, all of those measures that hospitals have been reporting on since the Medicare Modernization Act, and says, if you line it up, it is a perfect relationship, nearly perfect relationship, high cost, poor quality outcome. And he says the reason is that no one's accountable. You have these communities of care that have developed up, and he refers to them as hospital referral regions. HRRs come from the Dartmouth Atlas. And naturally, even though physicians don't mean to do this, they sort of naturally group around hospitals, that they practice around a hospital. And if you look at those hospital referral regions, no one's accountable. There's no one saying, this is how we should practice. This is when it's appropriate to order this procedure. This is the appropriate way to address these symptoms. There's nothing in the community doing that. No one's accountable to each other. And so he said, what we need to have are extended medical staffs, that we need to build these around hospital referral regions, and those physicians should be accountable to each other and have to meet performance measures as a system, not the individuals necessarily, but as a system. And one of the MedPAC commissioners said, that sounds like an accountable care organization, and whammo, the name stuck from that page of the testimony forward. From that testimony, back in 2006, generated the provisions of the Affordable Care Act that created the Medicare Shared Savings Program, which has really been driving this movement towards accountable care organizations. And the idea of accountable care economics is we have to start shifting the risk from the payer, who has every incentive to drive a profit, and thus manages the risks very aggressively, moving it to the provider, who is a professional that wants to provide high-quality, efficient services, and thus will appropriately engage to improve the quality of care. The ACO becomes the risk management vehicle, and that risk that they manage is the difference between total fee-for-service payments and an established benchmark. And they are held then accountable for the care through the care of those patients by performance measures. The calculation of the savings and losses, which is certainly a complicated formula, again, what is done in the secret hiding places of CMS where they analyze their data. Each member of an ACO is going to continue to bill fee-for-service, and thus this is a transitional model. Eventually we'll go off the dependency on fee-for-service, but this model of shared savings begins to transition us off of it. They then are eligible to participate in shared savings based on their performance scores, and we calculate a total cost of care. So everything that payer spends on services for that covered life, that is total cost of care, TCC. We're going to compare that to a benchmark, which is an historical approximation of total cost of care. And as long as apples are apples, that we're measuring the same exact services between the benchmark and the total cost of care, that should give us a difference, either a shared risk or shared savings. Under shared savings model, then the payer shares a portion of that savings with the provider. So not only does the provider get the fee-for-service payment, they're going to receive that shared savings. And you know, this is elementary, my dear Watson. All the money is in inpatient hospital admissions. If you look at Medicare data, the graph, the different, here's hospital inpatient admission costs, and then here's the next biggest expense down here, which is diagnostic services. So all the dollars are in reducing those inpatient admissions. When you appreciate that physician evaluation and management services, so physician interaction with patients, is 1% of what we spend on hospital inpatient admissions. And one can appreciate the incentive here under an accountable care organization is for the physicians to better engage with the patient, better engage with each other, keep them out of the hospital, reduce unnecessary tests, better manage their compliance with their plan of care. That's aligning the incentives where we want them to go. And so that is why the accountable care organization really becomes that first model of care delivery. Now, of course, CMS can't resist itself. So when you apply to participate in the Medicare Shared Savings Program, they give you a blueprint of what your ACO has to look like. And so it identifies the functionality of an accountable care organization. And really, it's a QO, a quality improvement, quality assurance program without walls. It's an organization of providers saying we're all going to adhere to the same QA program as opposed to keeping ours in isolation in our little place. And we're also going to be aggressive. We're also going to be aggressive in how we enforce our standards that we adopt collectively. And so if you're not playing by our rules, there will be consequences. And that's the incentives these create, which as you can see is very consistent with the idea of patient-centered care. And we're simply accomplishing that by moving the incentives. We're saying, hey, beat the benchmark, you get part of the savings. In a risk model, which we will slowly see evolving in, don't beat the benchmark, exceed the benchmark, you're going to share the risk with us as well. And that's coming. It's certainly not here, but that will be the next phase in our transition of payment systems. ACOs are certainly catching on. There are about 250 approved MSSP ACOs, Medicare Shared Savings Programs, about another 200 commercial-based ACOs. So these are provider communities that have a contract with a commercial payer to receive shared savings. This next round of MSSP applications, which the applications are due at the end of July to begin participation in the program in 2014, we think there are about 500 additional applicants out there. And with the rule clarifications, you're going to see many, many more of these coming on. And sort of things look sort of kind of light in the middle of the country. You're seeing that change too. And I think the next presentation, once I shut up, is going to be from the only ACO that's now operating in Kansas City. Hopefully it will have friends soon. But it is certainly a trend that is left the station. And anyone that thinks ACOs are dead upon arrival apparently was run over by the train as it left the station. Closing up real quickly on bundled payments because I don't believe in them, she says. Bundled payments were kind of promised as the great solution, that we should be able, if you have a surgery today, you're going to get a bill from the surgeon, the hospital, the anesthesiologist, the radiologist, the pathologist, the DME company, the physical therapist, you know the list. Wouldn't it make sense if we just paid one amount of money for that service and let those providers figure out how to allocate it appropriately? Wouldn't that make a lot more sense and be a lot more efficient? And we attempted a demonstration project, CMS attempted a demonstration project, and very quickly figured out that its data sucks and it really couldn't get this done efficiently. The data, it was very difficult to manipulate by providers because you had to analyze the data to figure out what the bundled payment should be. Historically, what have the costs been that Medicare paid? How do you bundle that together and identify the amount you would bid out? Hi, we'll do a total knee for this price, has proven to be a challenge. So I think bundled payments may still be on that fee-for-service incentive structure. And that's why we're struggling with it. That maybe the better way is simply to let the providers figure out through accountable care how to work together, how to be incentivized appropriately, and we may move right past bundled payments towards more global budgeting. But this is certainly one to watch, one that payers have expressed a great deal of interest in, and one that is insanely data intensive in terms of how you create the program and then allocate dollars. So maybe I am being too quick in my condemnation of the bundled payment program, because it certainly will receive some attention. So that was a whirlwind through the world of value-based purchasing and how it is moving you out of the, I hope, not unnecessary evil, probably necessary evil, but I think you're going to find yourself firmly entrenched in essential good, those who are critical to mission and generate dollars. Because in a value-based world, if you don't have data, you're blind. As you all know, I'm singing to the choir at this point, so this is when I should shut up because I always sing off key. So thank you for letting me talk with you at 8 a.m. on a Wednesday morning, and best of luck with the rest of the conference.
Thank you, Marty. That was a very good basis for what we're kicking the day off and kind of gives us the groundwork for where we're heading today. Marty set the stage to let us all know that all this information is what we as IT professionals need to know in order to keep our head up and be able to know what our role is. And as she was saying, at the end of the day, it's data, but there's a whole lot of work in between to get there. So that was a great start. So.